Hello, my name is Dr. Reshma Mahtani. I am Chief of Breast Medical Oncology at Miami Cancer Institute, Baptist Health, South Florida. Genomic signatures such as the 21 gene recurrence score and the 70 gene mammoprint index are routinely used to guide chemotherapy decision-making in the adjuvant setting. But overall, these studies the studies that were used to validate these gene signatures severely underrepresented older patients. For example, the MINDAC trial had an age limit of 70 years of age, and the age limit for TAILOR-RX was 75. Our exponder only had about 12% of patients that were older than 70. Therefore, when we see older patients with the diagnosis of early stage ER-positive, HER2-negative breast cancer in clinic, the issue of whether we should be utilizing chemotherapy in these patients is a common clinical scenario. And with that background, the Unicancer ASTER 70 trial was reported at ASCO 2022. The study enrolled a little over 1,000 patients aged 70 and older, undergoing curative surgery for an early stage ER-positive, HER2-negative primary breast cancer, or for an isolated local relapse, and included patients irrespective of the pathology in terms of tumor size and nodal status or other stringent pathology or patient-related criteria. And I think this is really important because it represents the types of patients we're seeing in clinic and for whom we often wonder if chemotherapy will be of benefit. Patients underwent genomic testing, and if low, no chemotherapy was recommended. And if the results were high, they were randomized to endocrine therapy versus chemotherapy, followed by endocrine therapy. The standard endocrine therapy was administered for 5 years, and it could consist of an aromatase inhibitor or tamoxifen. And in terms of the genomic assay, the trial used a genomic grade index as the assay, which is a 97 gene signature done by RT-PCR on formalin-fixed paraffin-embedded samples. Certainly not an assay that we frequently use or have access to here in the States. It's important to note that the Charlson Comorbidity Index and 4-year mortality Lee scores were collected at baseline. And in terms of the patients that participated on this trial, the median age was 76, but it ranged from 70 to up to 92 years of age. Importantly, this trial included around 40% of patients who were considered potentially frail, and about 16% had an estimated 4-year mortality of 50%. The investigators were really trying to get an assessment of not just the chronologic age, but the functional age of the patients randomized. And again, I think this is the strength of this study. For the primary endpoint in the intent to treat population with a median follow-up of close to 6 years, patients assigned to chemotherapy did not show a significant improvement in survival compared to endocrine therapy alone. It was 89.4% versus 90.6%. Of note, 11% of the study population overall did not take their medications as prescribed, and this rose to 20.5% of patients in the chemotherapy group. Not surprisingly, there was also a higher rate of side effects for patients given chemotherapy. In the context of the non-adherence to chemotherapy assigned, the per protocol analysis did show a potential advantage to chemo. But these numbers, the magnitude of difference was quite small, 89.3% versus 91%. So there was also a very similar outcome when looking at invasive disease-free survival, not significant in the ITT population, but there was a difference in the per protocol analysis. However, again, it should be noted that the benefits that were seen in this per protocol analysis were marginal at best. And based on these results, the researchers concluded that the GGI index was prognostic, but did not predict survival benefits with the addition of chemotherapy to endocrine therapy. And practically speaking, I would say that as we see these older patients in clinic, these data are extremely relevant in that they remind us that we have to be quite judicious in our use of chemotherapy in older patient populations where there are certainly risks associated with these treatments. And the take-home message is that careful selection of patients and individualized therapy are of utmost importance when making chemotherapy decisions for this population.